This is Brian Wormers recording a lecture on inflammatory intestinal disorders for medical surgical nursing. Here are your learning objectives. First thing we're going to talk about is appendicitis. So this is an acute inflammation of the appendix, which is a blind pouch attached to the cecum of the colon. The most common cause of right lower quadrant pain currently out there. Where you're going to see it most is at this McBurney's point, which is about 2/3 of the way from your anterior iliac crest to your umbilicus, or 1/3 of the way this way. And so it's right there. It does have some rebound tenderness with this, so what that means is when you push on that site, it doesn't hurt when you push on it, but when you let go of it, then that becomes irritated because of the psoas muscle. So this does hurt when it's irritated. But if the appendix ruptures, there's no more pain until this becomes a peritonitis and the patient becomes septic, and then they can become very sick. Non-surgical management of appendicitis can include making them NPO, starting IV fluids, giving them pain meds, and then starting them on some antibiotics, usually Flagyl and Cipro, and then allowing that to encapsulate. Some surgeons will wait for 6 weeks so that can encapsulate, and then they remove it at that point in time. Other surgeons will perform surgery within a short amount of time, and that's based on things such as, do they live in town, are they dependable, are they reliable, how much pain are they in, etc., etc. Do not give laxatives and do not heat, as that can make it both worse. Peritonitis can be from the appendicitis, but this is a life-threatening acute inflammation of that parietal peritoneum. It's that lining of your abdominal cavity. This causes decreased peristalsis, and that abdomen becomes rigid and board-like, and we talked about this before. There is a risk for sepsis, as this can get into your bloodstream and cause system-wide problems. Physical findings depend on the stage and immune system, but generally speaking, if they are having a lot of abdominal pain and that abdomen becomes rigid and board-like, you have got some major problems. Most of these patients look very sick when they present. They're often lying very still. They don't want to be touched on their stomach or move their stomach, and their knees are flexed to try and relieve pressure in their abdomen. Treatment for this can be IV fluids to hydrate them up, and then broad-spectrum antibiotics, once again like Cipro and Flagyl. We're going to monitor their daily weights and watch their fluids. We might put an NG down to suction out the hydrochloric acid in their stomach, make them NPO, and give them some oxygen and pain management. If it's bad enough, we can do surgery to try and do an irrigation of that, remove any foreign material. But sometimes this can spread that infection around a little bit and make an inflamed area even more inflamed. Postoperatively, we're going to be taking care of the incisions and drains, and they might even have an irrigation that you have to do in that peritoneal area. But generally speaking, it's mostly just regular post-op stuff. Gastroenteritis, so gastro means stomach, enteritis means intestine, and so this is usually an infection that is causing you to vomit and to have diarrhea. This can be from bacterial, such as Campylobacter, Shigella, E. coli, or it can be a viral, such as Norwalk virus. Ask about recent travel, if they've gone to any foreign countries or anything like that, if they've gone camping. Those can be big tip-offs for what you are dealing with. See what they have. Do they have any muscle aches with this? Do they have any headaches? Do they have any malaise? Are they dehydrated because they've been losing so much fluid? Some of the interventions you can do with this would be fluid replacement, so starting an IV and giving them some fluid, otherwise nutritional supplements. Rarely we'll start on drug therapy, such as antibiotics, but we've got to be very careful with this one. For E. coli, if it's the 0157, toxin, that one can be very bad if you give antibiotics because you lyse it open, and then it tends to be very hard on your kidneys because you have a lot of toxins that are released all at the same time, and that can really damage your kidneys. So we have to know what we're dealing with before we put them on broad-spectrum antibiotics. The other thing is be very careful of starting any antiemetics or antidiarrheals, because the purpose of this is trying to eliminate that organism. If you make them stop puking and pooping, which they might appreciate, they're going to get sicker, and they're going to stay sicker for a longer period of time because they can't purge that out of their body. With this, also be careful with skin care. If they're stooling a lot, that can be very caustic to their skin, so make sure that you're providing great peri-care. Alright, ulcerative colitis. This is a form of IBD, and it's widespread. So this goes, since there's the word colitis in there, it's in the colon, and so make sure that you realize that it's just the colon that this is affecting. But this can cause loose stools, blood and mucus in the stools, poor absorption of nutrients, and then thickening of that colon wall. These patients are at increased risk for colon cancer, and there is a familial trait with this. Physical assessment, they might have a low-grade fever. They're going to usually have some tenderness with palpation of their stomach, and they're going to have some tenesmus, and that is an urgent cessation to defecate and some colicky pain when they actually do defecate. Psychological assessment, this can be very disruptive and stressful in their life, so make sure that you're trying to cope with this and be accommodating to that. Laboratory assessment, so oftentimes we're doing H&H just to see how much blood that they've lost, WBC to see if it's elevated, CRP and ESR for infection and inflammation. I should say not necessarily infection, and then electrolytes to see how they're absorbing and how much they're losing. Other diagnostic tests, there is some blood work for this, and that's one of the few ways to try and distinguish between ulcerative colitis and Crohn's, and we'll talk about that in a little bit. Colonoscopy is one of the definitives for UC versus Crohn's. On your exam, I highly recommend you be able to distinguish between ulcerative colitis and Crohn's disease. Treatment-wise, we can give aminosalicylates, so calming the body down with those, or with steroids. We can also give immunomodulators, trying to calm the body down as well. We can give anti-diarrheal drugs, but just got to be careful with that one. If that colon becomes too dilated because they're not stooling, it can cause perforation, and that can be very bad, as that will cause peritonitis. Other things that we're concerned about would be nutritional therapy. So if they can't uptake their nutrition that way, you might have to start them on TPN. And then try to give them some rest, both emotional and physical rest, to help them out. Alright, the counterpart to this is Crohn's disease. This can happen throughout the whole intestine. This can be in the small intestine, the colon, and actually, by definition, it can be from mouth to anus, but usually it's on that terminal ileum. So on the other one, you can treat it by taking out the colon in very severe cases. In this case, you don't want to, because if you do that, you kind of end up taking bit by bit by bit by bit, and it just progresses until you make more problems doing that. So this one also has malabsorption problems because of the inflammation, and so you have to be aware of that. With Crohn's disease, it is more likely to cause fistulas, which you can see up here and here. This first one is the intestine out through the skin, and the other one is an intestine to an intestine. I did have a patient that had an intestine into the bowel, until this patient presented with chronic UTIs. Drug therapy is very similar to UC meds. You're trying to calm the body down, so a lot of steroids and immunomodulators. Have to be a little careful with these fistulas because you can cause infections depending on where they're draining into. Nutritional therapy, once again, is going to be important. TPN might be a mainstay for this. Fistula management, generally speaking, if you can calm the body down, the fistulas will repair themselves and do not require surgical intervention. Fluid and electrolyte therapy, that's usually tied into your TPN. Skin care, once again, if they're having lots of bloody stools and frequent stooling, you got to make sure you're taking care of that good peri area. Also trying to prevent infection. If they are on immunomodulators and steroids and all those things to calm the body down, they're more susceptible to infection, so we have to be careful with that one. And on this one, like I said before, surgical management is very conservative. You do it if you absolutely have to, and even then you don't want to. Diverticular disease, this is a pouch-like herniation off the wall of the intestines, and what happens is usually a food particle will get stuck or something will get stuck in there, cause irritation and inflammation of the diverticuli, and that can cause problems. If it gets bad enough, it gets swollen enough, it can actually rupture and cause a peritonitis. Generally speaking, these do not, but patients can present with signs and symptoms of abdominal pain, nausea, vomiting, fever, chills, tachycardia, Diagnostic stuff, basically we're looking for a WBC to see infection, and then also what we're going to be doing is looking for x-rays, CTs, or colonoscopies to try and find these little outpouchings. So with this nutritional therapy, you want some fiber in the diet, but no seeds such as popcorn, corn, or even the little seeds on the strawberries, because it can get into those tiny spots and cause problems. Give them some bowel rest, do IV fluids to hydrate them up. Can give them antibiotics to try and prevent any infections and peritonitis. You can give anticholinergics, you can give some pain meds, you can make them NPO. Try to avoid the laxatives and enemas because that site's already irritated, and that can put them at further risk for peritonitis. Can do surgery on this if it's severe enough or if it ruptured, and then you can do a resection of that bowel and take that area out. Celiac disease, your book doesn't have a ton about celiac disease, but basically this is a multi-system autoimmune disease of the small intestine. Some of the signs and symptoms that you might see would be anorexia, diarrhea, constipation, fatty stools, bloating, and some weight loss. The mainstay for this is to remove gluten from their diet. Gluten is part of that wheat. So we are getting better as a society to try and have gluten-free foods, and you're going to see that more in your supermarkets. Last topic here is going to be infections via parasites and pinworms and tapeworms. So if you click here and here, you're going to be linked to different YouTube videos to see some of these things. Pathophysiology, generally speaking, this is spread through fecal-oral transmission. So then contact with, either directly or indirectly. And then hand washing is one of the best ways to do to prevent the spread of this. Suspect-wise, have they had any travel into different areas? Any GI symptoms, diarrhea, cramping, fatigue, weight loss, fevers. And then interventions, we can give drugs to clear those up and kill them, and then support them with some IV fluid for some therapy. With worms, basically they're going to have perianal itching, especially at nighttime when the worms will come out. One of the easiest ways to see and to diagnosis is to use double stick tape around the rectum. And in the morning, if any of the worms are stuck on the tape, that is one way to know that that's positive. Once again, lots of hand washing is great things with this. And we can give medications to kill these. Tapeworms, these can be very benign, otherwise they can have lots of GI upset with nausea, vomiting, and diarrhea. Diagnosis, generally speaking, we send a stool for sample and we notice that there's some eggs and some parasites in there. This is often a result of undercooked food or contaminated water, and this is very common in third world countries. That concludes this video. If you have any questions, please talk to your professor.